I'm one of the pediatricians from Kettering General Hospital, and welcome to Technology Enhanced Learning. As I've said, I work at Kettering General Hospital and I've been practicing for over 7 years now. My special interest is neonates and pediatric cardiology, and I'm a keen enthusiast of simulation-based education and patient safety. I chose to talk about respiratory illnesses in infants as it is that time of the year. Any presentations comprise of respiratory illnesses amongst the younger generation as the predominant presenting feature. The 2015-2016 data shows 450 per thousand A&E presentations amongst the younger generation less than 25 years of age. The 5 most common conditions are diagnosed on emergency admissions in infants comprises mainly the respiratory ones. And to top the list is acute bronchitis or acute bronchiolitis in the younger generation, in the younger infants. So it's not surprising that I chose to talk about bronchiolitis as it is quite relevant to this time of the year. And to be honest, I think we all find some of the challenges in management of these little babies as well. So, what is bronchiolitis? At the top image, you see the bronchiole, which is a branch of the bronchi. Bronchiolitis is acute infectious inflammatory disease of the respiratory tract. And it also happens to be the most common disease during the first year of life. We usually see that during the winter months, starting from October up until March, and it tends to tail off during April. What is the incidence? It is about 1 in 3 infants, as is shown in this infographic, who tend to be affected with acute bronchiolitis. And about 2 to 3% of them result in hospital admission. Preterm babies and babies who are less than 10 weeks tend to be the higher risk infants who tend to be far more sicker and more symptomatic. And obviously, where there is the presence of comorbidities, babies tend to be far more unwell. These comorbidities tend to be either chronic lung disease in the preterm babies, cardiac conditions that are hemodynamically significant, or others such as immunodeficiencies. So, what are the causes? I would like to touch base on pathophysiology along with these causes. Common viruses such as RSV, parainfluenza, influenza, and adenovirus are isolated in children presenting with acute bronchiolitis. RSV tends to top the list. About 30% of children could have co-infection with 2 or more viruses. Where RSV is noted, we usually see that the children are more severely affected, and particularly so if there is a co-infection as well. Now, talking about pathophysiology, we see the bronchiole lumen here. And in bronchiolitis, what we are seeing here is intense inflammation. As a result, there's lots of mucus secretions. With mucus secretions, there can be colobar collapse or atelectasis as well. Now, what about the course of illness? This is equally important. It helps to prognosticate to some extent which way or in what manner the child might behave. It tends to peak about day 3 to day 5 of age, and then you can see that it plateaus a little bit with eventually getting better. It's also important when you see the child in A&E, for example, if they are on day 1 or day 2 of illness, to safety net the carers and the family for the potential of further worsening that might then need a hospital admission. So what about the clinical features? Now, a typical clinical presentation would start off with viral illnesses, predominantly upper respiratory tract symptoms such as coryza or runny nose, and over a day or so then can progress on to lower respiratory tract symptoms such as tachypnea, coughing, etc. Here is a presentation of a child who has RSV positive bronchiolitis, and note the respiratory distress. What about management? Now, there has been extensive research that has gone into looking at the management aspect, and I would like to break that down in investigations and supportive care. A typical infant would present with predominantly respiratory symptoms, and hence one might think about chest radiography, one might think about blood cultures, full blood count, a blood gas, etc. Where the presentation is quite typical of acute bronchiolitis, actually none of these are indicated. And including pulse oximetry, a continuous use perhaps is not that helpful. Intermittent checks should be performed in all children. If the presentation is quite typical, there would not be any need for any more investigations. Now, what about the management in terms of supportive care? There are two aspects which are quite affected in bronchiolitis. One is the feeding, and the second is the respiratory status. Feeding support is provided with the use of a nasogastric tube, and the respiratory support with oxygen administration as needed, as well as some escalation in care in a small minority of children with initially high flow nasal cannula oxygen, which is noted in this image here, and in a small proportion of children who might go on to needing intensive care. So if I were to summarize, the management would consist of minimal handling. There's really no role for routine x-rays and blood tests as we've just discussed. Antibiotics you do see quite a bit with bronchiolitis because the hemodynamic parameters are quite similar and would trigger on the sepsis 6 parameters. However, this is a well-recognized sepsis mimic. And in such situations, it probably calls for a senior input to make the decision about de-escalation. And hence, there is really no need for antibiotics either, unless there is a suspicion of secondary bacterial infection, in which case the course would be different. There's also no role for nebulization or adrenaline or steroids in the overall management. So finally, the prevention aspect, which is equally important. On ward runs, we would advise regular hand washing or even amongst family members as well. It is quite important to keep toys and surfaces clean by frequently washing or wiping them. Smoking should be avoided. There's also the role of pylivizumab, which is a monoclonal antibody that is used in the prevention of RSV in high-risk infants. And the high-risk infants, as previously alluded to, will consist of preterm babies with either chronic lung disease, or if there is a hemodynamically significant congenital heart disease or other conditions that might predispose them to a severe course of illness. So to summarize, acute bronchiolitis is the most common infectious disease of the respiratory tract in infants. The clinical course might worsen before it improves, and minimal interventions and supportive care is the mainstay of management. Again, hand washing is equally important. One must consider monoclonal antibodies, especially in the high-risk groups during the winter months. And there are criteria for the same, which are easily available on the internet. Thank you very much for listening.